Hello, everyone, and welcome to aidsmapLIVE, Decades of HIV. My name is Susan Cole, and I'm thrilled to be joined by an absolutely incredible panel that I will introduce to you now, one at a time. First of all, can I have Josh?
And here I am, Susan. Here I am.
Hello, Joe. So, Joe, for those of you who don't know her, is an HIV activist and a writer, also communications officer at the British HIV Association, and is on the steering committee of UK CAB, as well as loads of other very impressive things. So, Joe, how long have you been living with HIV?
Well, I was diagnosed in 2008, which was the year of the Swiss statement. And for those who've not heard of it, it was very much the forerunner of undetectable equals untransmittable, or U equals U. In other words, the first thing that suggested that if you were on treatment, you could not pass on HIV to anybody else. At the time, I was told not to talk about it because I was like clinging to that like a drowning man grabs a life buoy, because it was sort of hope, but told not to talk about it by a community of clinicians who were very risk averse.
Wonderful. Well, thank you very much. I will ask you to come back on in a moment. If I can have the next guest, please, Dr. Tristan Barber. Hello,
Hi,
Tristan.
Susan.
Hi.
How are you?
I am very well, very excited to be doing the first aidsmapLIVE of the year and to have you back on. So for those of you who don't know Tristan is an HIV consultant at the Royal Free Hospital and one of the world's leading experts on HIV and aging. And Tristan, can you tell us how long you've been living with HIV?
Thank you, Susan. That's very kind. It's lovely to see you. It's great to be here as ever. I've been living with HIV now for 19 and a half years. I've got a big anniversary coming up in July.
Wonderful. Fantastic. Thank you very much. And I was going to ask you, over that almost 20 years, one highlight for you.
Oh gosh, there isn't. I mean, there's one, but it encompasses many things, or should I say many people, and it includes all of you on this meeting this evening, which is all the fantastic people I've met over the course of not only living with, but also working in the field of HIV, both within London, locally, nationally, across the UK, across Europe, and of course, globally. It's a fantastic community to be part of. And I think we really do work well together in terms of including the people that are directly affected by HIV or at risk of acquiring HIV in all the work we do, both clinically and also hopefully increasingly in the design of our research studies.
Wonderful. Thank you very much. I shall see you in a moment, Tristan. And next, can I have up Rebecca?
Hi, Susan.
Hi, Rebecca. So Rebecca Mbewe is a speaker and trainer, co-director of the Women's HIV charity, the 4M Network of Mental Mothers, and one of the leads of the GROWS project that's looking at issues affecting women over 40 living with HIV. Thank you so much for coming on, Rebecca.
Thank you, Susan. The pleasure is mine.
Wonderful. How long have you been living with HIV, Rebecca? And can you tell me one highlight over that period?
Okay. I have lived experience of HIV of 25 years. And I guess the highlight is being at this end of the 25 years and being able to grow older with HIV and leading on a project that actually highlights some of the challenges, but also the pleasantries. So yeah, that's the highlight of my HIV journey.
Wonderful. Thank you very much. I will see you in a moment. And finally, can I have on Richard Desmond?
Hello, Susan. It's good to see you.
Hello, Richard, wonderful to have you on. Richard has a long and illustrious history in LGBT activism and HIV activism, but I will read how Richard describes himself. Richard was chief electrician at the Savoy Theatre until stopped by ill health in 1993 and has been trying to be useful while avoiding death ever since.
The Savoy was my job. It kind of identified me, and HIV stopped me working, and that was something that happened in the 90s that wouldn't happen now.
Yeah, absolutely.
And I've been diagnosed for 37 years in August. Probably positive for a bit more than that. The thing that is a kind of highlighted period has to be about 1996, when ARVs came in and the world changed. It's difficult to think what life was like before ARVs, because we've had them now for so long. But them coming in was the big change that was a massive highlight for me.
Yeah, absolutely. Very, very important year. And we can discuss that a little bit later. So thank you very much. Now, can I bring on everyone back, please? Hello, everybody. So I've had lots of questions so far sent over to me, but the one question that I get asked more than anything else is, what is the life expectancy for people living with HIV? Tristan, can you answer that?
Well, thank you very much, Susan. I mean, I think tapping into Richard's point, this very much depends on when you were diagnosed. And if you're diagnosed now in a fairly well-resourced setting, Western Europe or North America, and you're diagnosed at a fairly early stage from the time that you've acquired your HIV and put onto treatment in a reasonable time, then you've got a very, very normal life expectancy. We know that people with HIV can still have an excess of certain conditions, including some types of cancer and including tuberculosis or TB infection. But because we follow people up regularly and monitor them, we pick these things up early and the outcomes are very good. So life expectancy overall can be really, really excellent. Now, I think we do need to remember, though, in the global situation, many people are still diagnosed late. Indeed, unfortunately, even in the UK, we still have a proportion of people that are diagnosed late because they don't see testing messages or prevention messages as being something that they should be engaging with, or perhaps they're not really made for them, perhaps they're targeted at different populations. And I think if people are diagnosed late, then unfortunately their HIV may have some impact on their life expectancy overall, but nonetheless they can have a really excellent and very near normal life expectancy. But this is why it's very important to test regularly and to pick people up as early as possible after they've acquired a new infection with HIV.
Wonderful. Thank you very much, Tristan. And I just want to say to everybody that Matthew Hodson, the chief exec of NAM, is backstage monitoring our Facebook and Twitter. So get your questions over. So I have another question for you, Richard. When you were diagnosed all those years ago, did it cross your mind that you would live so long with HIV?
I didn't think I'd live this long with HIV, and neither did the company that bought my life insurance. There was the people who work out life insurance. They bought my life insurance on the basis I was going to be dead. I had a DS 1500 that said I'd be dead in 6 months when I started claiming benefits. The reality wasn't like that, but we weren't to know at the time. Immediately after diagnosis, my late partner and I saw a brilliant psychologist called David Miller, and we went in thinking that we were going to be dead and came out thinking, well, what should we do with our lives? And both Bob and I went on and did things that we probably wouldn't have done if we hadn't been diagnosed, despite the fact at that point in 1985, it was realistically an indication that we weren't going to live that much longer.
Right, absolutely. Thank you for sharing that. And Rebecca, you were diagnosed 25 years ago. Has the reality of living with HIV been different to what you anticipated?
Yeah, very much so. Because in '96, when we were diagnosed, or when I was diagnosed, the prognosis was that you would live just a few years and a few months. So yeah, it was really, it's very different. The outcome is different. When we were diagnosed, it was questionable as to whether you could have a baby. And that, a few years later, then became a reality. So we were literally being prepared to die. So we had stuff like memory boxes, and we had, being prepared, being told, make a funeral plan, because that's what the prognosis was. And then, this far down the line, yeah, it's very different from what I had anticipated.
Right. Okay, thank you. And Joe, as someone who was diagnosed in their 50s, do you think that women in particular are told enough as we get older about the risk of HIV?
I think it's not so much are women told enough, it's are we actually exposed enough to information about it in such a way that it makes us believe that it affects us. Because when you are no longer in the position of risking pregnancy, you don't think that anyone you sleep with is going to be like the sort of person that you typify, who would have HIV. When I was diagnosed, I knew absolutely nothing, not a thing about it at all. And I don't really know how that can be changed unless you get people like me out there talking about it.
Yeah, thank you. And Rebecca, is that something that you're finding, that women just aren't knowing enough or being exposed enough to information about HIV?
Yes, I agree with Joe, actually. A lot of people diagnosed, excuse me, slightly later in life, have exactly the same assumption that Joe is talking about. I'm now no longer at risk of getting pregnant, so therefore it's okay. And I've probably been in a relationship really long. So those are the sorts of things that people don't bring to mind, first of all. So yes, I agree with Joe. Women are not being exposed nearly as enough as they should be.
Thank you. One thing that comes up a lot in conversations that I'm having with people living with HIV are the other types of health conditions that they're experiencing. Tristan, what are we seeing most commonly?
I think things we see most commonly as people age, again, it kind of depends when you were diagnosed. We're touching on some of this already, but I think let's take the UK. If you were diagnosed before 1996, you didn't have access to conventional or to triple antiretroviral therapy, to combination antiretroviral therapy, you were much more likely to live with a low CD4 count for a long period of time. And when you started therapy, you were much more likely to get quite toxic drugs that had a number of side effects, both short-term and long-term. So we still have people with peripheral neuropathy, we still have people with body fat changes, and so on, and other complications of not only the drugs, but also having had AIDS-defining conditions. If you're diagnosed after 2015, after the START study, you're obviously put onto immediate antiretroviral therapy. Now, you can be 70 and have been diagnosed in 2017, or you can be 70 and have been diagnosed in 1985. Now, obviously, those people are going to age very, very differently because of the different time periods when they acquired their HIV infection and the way that they've been treated. But I think it's fair to say the things we do continue to see across the board at a slight excess are certain types of cancer, certainly in gay and bisexual men, we see an excess of anal cancer, for instance. We also see in all people with HIV different presentations of lung cancer. There's more it's called a type of lung cancer called adenocarcinoma that we see more commonly in people with HIV than people who are not living with HIV. Also, there remains a slightly increased risk, although it's fairly low overall, but relative to people not living with HIV, there is an increased risk of a type of cancer called lymphoma that we have to be very, very aware of. And then what we are seeing now as well in people, certainly those who've been living with HIV for a little longer, we're certainly seeing an excess of cardiovascular or heart disease. There was a study at the recent CROI conference showing in America that it remains the case that there's about a 60% excess of heart attacks in people with HIV compared to people not living with HIV. And in addition, we perhaps see a little bit of an excess of bone disease, kidney disease. Possibly people get frailer a little bit quicker. They may have a premature menopause. Sorry, this is a little bit of a list. We don't, as I say, we don't really see this so much in people that are diagnosed more recently and put onto treatment sooner. But I think this is why people really still need to be attending specialist HIV services, because as HIV physicians, we've kind of got our eyes wide open for these slightly different presentations, sometimes more frequently, sometimes earlier than they would occur in people who are not living with HIV.
Right. Thank you. And I would like to ask everyone, do you have any other health conditions? Starting with you, Joe.
I live with peripheral neuropathy, but it was not caused by medication, because I had it from like day one, seroconversion, very badly, and still do. It hits people perhaps with HIV a little more because of some underlying inflammation, but it isn't really totally understood as to why it does. But Tristan, I don't know if you know this, but I've been doing a lot of global research on it, and certainly about 40% of people living with HIV will have peripheral neuropathy. And for people watching who don't know, what that means is most commonly that you get pain in your feet and your lower legs, also sometimes in your hands, so that you maybe can't lift heavy things. And while it is not curable, and the treatment you're offered is largely painkillers of different types, you can live with it. You certainly can adapt how you are and how you look at pain in order to just sort of get on with your life, which is what many people do, and what I certainly have tried to do.
Thank you. And Richard?
Just concurring with what Joe said, how we adapt to the symptoms and manage the symptoms. Peripheral neuropathy I've had as well. Of my 13 pills a day, 3 are for HIV, others for blood pressure and cholesterol and things like that. Getting older, these things happen anyway. Having had prostate surgery and neuropathy and living with these things, the one that's always embarrassing, and Marquez King wrote brilliantly about, was the fact that people with HIV tend to have more gut problems than people who don't. And I certainly have lived with that, but you learn to manage it. It may not be a regular pattern that people you learn to, I have learned to cope with it. It's something I deal with rather than taking remedies for, because the remedies are often worse than the symptom.
Thank you. And Rebecca, any other health issues?
I think I fall in the category that's quite fortunate, actually, touch wood, other than the occasional sort of inflammation and very poor circulation, which I doubt has got anything to do with HIV. I've just always been a rather cold person. Nothing diagnosed. So yes, I always say I'm very, very lucky. I don't have high blood pressure. My cholesterol, apparently I was told today, is a little bit on the high side, but other than that, I'm fairly well and coping really well with HIV.
Fantastic. And how about you, Tristan? health-wise.
Also, fortunately, quite lucky that I don't have any other currently diagnosed conditions. If I could pick up on 2 points other panelists have raised. I agree with Richard entirely. I think we know that HIV very early on affects people's bowels, and we know that you lose a lot of white blood patches that line your gastrointestinal tract very early on in HIV infection, and many people complain of bowel symptoms that never fully resolve. And I think with regard to Joe's point as well, I think what we're starting to see in terms of a kind of coming together perhaps of pathways for all these different problems that people encounter more severely or perhaps earlier with HIV, including peripheral neuropathy, is that we think some people, and actually this has probably been shown in COVID as well, with long COVID, some people are perhaps more inflammatory than others. So something attacks you, be it an infection, it doesn't need to be HIV, it might be another infection like COVID. And some people's bodies respond to that super strongly, in a very pro-inflammatory way. And it may be, I don't know the answer to this yet, but those are the people who suffer more severely with peripheral neuropathy because they're very inflammatory very early on. Other people, perhaps like Rebecca with no other conditions, perhaps their bodies or their immune systems just kind of tolerate things a little bit more and just kind of go, oh, we'll just see what this one's doing before we leap on it. And perhaps those people, because their immune systems work in a different way, perhaps they don't get as many problems early on when their bodies are reacting to something that's invaded them, if you like.
Yeah, no, absolutely. Thank you very much, Tristan. And for many people suffer from a variety of comorbidities at the same time. And one issue that comes up a lot is people being ping-ponged between multiple doctors. Has that been anyone's experience in terms of if if you have one illness, your GP bounces you to your HIV consultant or then to another specialist? Is that something people are hearing about?
I had that a fair bit to start with. I was really lucky because my GP didn't have a clue. I have introduced every GP I've ever met now to the Liverpool Drug Interaction website because it does help them significantly. But it doesn't fill you with confidence when your GP is frantically going through things on a screen and comes out with information which is significantly lower in quality, shall I say, than the information you actually have yourself about your condition. With peripheral neuropathy and the painkillers bit, one of the gabapentin and amitriptyline are two very common prescriptions. Both actually are used for other health conditions, but may, and I say may, have some benefit for people with peripheral neuropathy. My GP, I am a small woman, decided the only way to see whether it worked or not was put me up to the maximum dose, by which time, I mean, you could have cut my legs off, frankly. I was just like this, I mean, I was watching every soap there ever was on television like that, occasionally making little giggles, but otherwise nothing was happening here whatsoever. GPs had their training on HIV, if they did, because it does tend to be, Tris will help on this, but it's just a few weeks in the general medical training. And for most of them, it was years ago. So, I mean, they don't know that treatment will make sure that you don't pass HIV on to anybody else. They don't know about different treatments. They really genuinely don't know, and it can be awfully tiring trying to educate them and the people in A&E that you meet when you fall over, as I have done before now, and so on and so on. And I sort of feel I've got to try, because that might make it a bit easier for the next person that comes in. In the good old days, there were specialists in HIV clinics, so you got mental health support, which a lot of people need. In your HIV clinic, you actually had a psychologist who understood, as opposed to didn't have a clue, like the IAP people these days. You had a dietitian, you had all sorts of specialisms that you really wanted to have. Now, if you're lucky and you have a really good clinician like Tristan, then there is a pathway in your clinic which will set you up to go to someone who does understand the relationship between the condition you've got and HIV.
Yeah, absolutely. And Tristan, what would you recommend to someone who may be facing challenges dealing with multiple health professionals?
Yeah, I think this is such a great question, and it's so timely. I think we have to bear in mind that for some people at some clinics, particularly the larger ones, they actually get access to integrated care more rapidly than people who are not living with HIV. So there's a slight inequity problem here, not only for people living with HIV, but for people who are also not living with HIV. You know, for some clinics, you can get rapid access to a psychologist, you can get rapid access to a liver clinic, but certainly in and many other examples as well. But in smaller centres, and obviously in less well-resourced settings, there may be a real problem with care fragmentation. And I personally feel our GP colleagues are wonderful, but even in a large GP practice, let's say they have 10,000 patients on their books, you know, they may only have a handful who are living with HIV, only some of which may be prepared to have their HIV status discussed with their GP. And when they've got so many other priorities, I think educating GPs to a level where they can really provide specialist care would be very difficult and probably not at the top of their priority list. So I think what we have is a duty now as HIV clinicians to adapt, whether we work in large or small centres. And the thing I will say when I speak to people in smaller centres, you know, they'll say, how do we develop, you know, we don't have access to psychology. What do we do about people with cognitive impairment? What do we do with people about frailty? And I will say, look, are all your appointment sizes the same? Are they all 15 minutes? Are they all 20 minutes? And they'll say yes. And you say, well, what proportion of your patients are stable? How many are coming in and their viral load's undetectable? They're like Rebecca, they don't have many other problems, and all they really need is their antiretrovirals and their blood results, and they can go. And they'll say, well, about 40–50% of our patients are in that category. So you say, why not flex your appointments a bit? Why not have some 10-minute appointments and some 40-minute appointments? And you know, you may not have the volume of patients to have a dedicated memory clinic, but if you spend 40 minutes with the people who are a little bit more complex and go back to basics and take a full medical history and go through things that aren't just HIV related, perhaps they'll tell you a bit more about other things that are affecting them. And what I will then say is you can then play a real role in care coordination. You might not be able to provide every single aspect of their care. You might be limited in what you can prescribe, for instance, within an HIV service. But what you can say is, would you be happy for me to help you coordinate some of this, include your GP, include other specialists, and try and knit things together for you? And I think that's a really important first step. Why give everyone a one-size-fits-all appointment if you know that half your clinic are well and happy and they want their viral load and 8 months of medicines and they'll go on their way? You're doing the other people a disservice if you also try and squeeze them into a one-size-fits-all clinic. So just try and offer some flexibility is a really good first step.
That's very good advice. Thank you. And Richard, how important has information been for you in terms of managing your health, living with HIV for many years?
I had the good fortune to use the original paper version of NAM, teaching people how to use it. Information has been understanding what's happening with the virus in me, has enabled me to have some sense that I have some understanding, if not control, over what is happening with me and the virus over this long period. Information has been absolutely essential, and aidsmap has been a phenomenal part of that. And of course, it started in the London Lesbian and Gay Spiritual Forum, where I've been a volunteer for a very long time.
Fantastic, thank you. And it's, yeah, if anyone's not familiar with aidsmap, do go and check out the information. Very good website. Rebecca, have you found that women going through the menopause living with HIV are facing any particular issues?
Yes, I think it's important to highlight that actually one of the findings is that women living with HIV are more likely to have an early menopause. And one of the challenges to begin with is not even understanding what's going on. There's very little information other than what we have, the PRIME study, which is a really good study on women living with HIV and the menopause. There hasn't really been much that's been published. And obviously, everything that we're exploring is still at that point where we're just literally trying to work things out and find out a bit more information. But with the menopause, I think the women that we've had conversations with, particularly as we develop the GROWS project, which is the Growing Older, Wiser, Stronger project, which is a collaboration between the Sophia Forum, Positively UK, aidsmap, NAM, aidsmap, and UCL. We're still trying to explore, lots of other areas. And what we found, or what the women have said, is that their challenges mainly to do with a lot of physical and psychological issues. And that comes with living with HIV, but also just as a consequence of growing older and the menopause and, all the symptoms that come along with it. A lot of brain fog. I can certainly attest to that myself. A lot of fatigue and pain, and, those are the kinds of things. But interestingly, one of the other things that they're finding that they're having to deal with a lot are the very practical issues. They're worried a lot about their financial positions when they get, as they grow older. Will they have enough money to live on? They're also very concerned about their care plans, because caring for somebody living with HIV is slightly different from caring for somebody who's living without HIV. So, yeah, quite a few challenges when we're talking about the menopause.
Yeah, thank you. Thank you very much for sharing that. And I know you raised the issue in terms of emotional well-being and mental health and HIV. And Richard, what would you say is the psychological impact of having lived with HIV for many years?
I would make a distinction between the impact from my generation and those that came after us. I think that we cannot be other than traumatized by what we lived through in the late 80s and early 90s. There is no getting away from that. But I also need to acknowledge that has changed. Now, as Tristan was saying, we can talk about normal life expectancies. We can talk about the joy of you equals you. It was different previously, and we carry that baggage with us intentionally or not, because it is what we live through. And when we look at my late partner's been dead 30 years in April, but there's not been a day in those 30 years I've not thought of him. I can't help but have that. That doesn't. Other generations, we don't need to pass that on to. We need to have good messages about HIV now that are very different from the days of tombstones and icebergs.
Yeah, absolutely. And Joe, as someone who was diagnosed most recently, does that resonate with you?
Well, I'm like the baby of the group, aren't I? I've only been living with HIV. I'm a teenager, 14 years, not like you lot. My daughter is younger than the virus that Richard's got. So, yeah, it's quite a bit. Anyway, surprisingly, perhaps, when I was diagnosed, it was just very scary. I was just going to say it was just as scary, but it can't have been. But I thought I was going to die. I thought that was a possibility. When I was told I was HIV positive, all I remember from probably 15-minute conversation is me saying, I can't die, my daughter needs me. And this specialist HIV nurse saying you could live to be 100, right? That's all I remember. It was still a big shock, I think, but I don't know if you were diagnosed now or if you're from a particular group, you may have more information already there. If, you are a gay man, you may well have a certain context for HIV that a middle-aged woman like myself would simply not have. I often say to people, there are 67 million people in this country, and only just over 100,000 of us are living with HIV. So the chances of coming across someone in your own peer group are quite small, perhaps, particularly when you are in a group that doesn't commonly become exposed to it.
Yeah, absolutely. Thank you, Jo. And Rebecca, as a woman of colour, women of colour face intersecting forms of stigma and discrimination. And what are you hearing from women who are perhaps diagnosed a little bit older with HIV?
Oh, where do I start? I mean, there are lots of factors. Culture comes into it. You know, I understand, for example, the difference being diagnosed very early on is probably very similar to how people in sub-Saharan Africa are diagnosed, because you see HIV literally all the time. The trauma is slightly more, I don't know, it's really bad trauma. And I'm not saying that it's any different from somebody who's diagnosed now, but I think when you actually see it on a day-to-day basis, it has a much bigger impact on you psychologically than it would do somebody who just heard about it or seen the adverts on telly. That's the difference I'm trying to make. I mean, so coming from that background and then coming to a country where you have to learn the health system, for some it may be that they have language barriers, they don't really understand or can interpret, you know, English from the local language that they know. They have to, some people come as spouses and therefore have to rely on somebody else for, you know, their financial stability. And all of those are things that compound you living with HIV. It just makes it that slightly worse. You know, there's also things around domestic violence, because it may be that as a woman, you know, you were diagnosed first when you went to antenatal. You know, for example, I've been living with HIV for 25 years. So if I happen to go to the clinic first and get diagnosed whilst pregnant, it's very easy, or what is often the case, that your spouse will then turn around and say, well, you know, this is something that you brought into the family, and it just exacerbates the abuse, whether it's physical or psychological. So yeah, there's loads and loads to unpack there. It does make it slightly more difficult. Not a conversation for a completely different.
Absolutely. And what solutions, you know, what helps you in terms of emotional well-being, sort of like getting older with HIV?
I think very first for me is the peer support, and that's carried me through right from my diagnosis. Even now, as you've grown older, there are my peers that are going through the same sort of you know, journey, slightly different obviously based on their different lifestyles and where we've come from, but you're primarily going through the same journey. We're aging. Is it HIV? Is it just rickety bones because I'm now over 50? And all of those kinds of things. So peer support is really, really important. And it's through that peer support you get strategies of how to manage, you know, manage your diet, or just do some mindfulness, and, you know, and you get loads of different ways of managing all the issues. You talk to each other about being assertive when going to see your doctor, have strategies about, if you can't remember why you're going in the first place, just make sure you write them all down, so that when I come and see Tristan, I'll say, right, these are the things that I need to talk to you about. So that way, so yeah, loads of ways of trying to manage your emotional well-being. Yeah.
Brilliant, thank you. And Richard, how important has exercise been for you?
I'm very fortunate. I can get to Tottenham Court Road relatively easily. And at YMCA, there is the Positive Health Scheme that the only thing I'm close to being evangelical about. It has been remarkable for me, not that I have lost much weight or changed my body shape hugely, but I feel better for doing it. And because I'm not working, it gives me a focus for what I do in my week. And there are lots of other wonderful, positive people on the scheme. And there are great role models, and it is a wonderful thing for me. I would encourage people to think about how exercise not only can help physically, but I honestly believe it helps me emotionally, and I feel better for doing it.
Fantastic. Thank you. And how about you, Jo? What's been helpful for you?
Well, all of the people that I have met in the HIV community, this is my tribe. You know, there's really good things about living with HIV because you get to meet all of these really great people. And because they're just sort of like getting on with life and being nice and being happy, it makes you think, okay, I can do this too. When I was first diagnosed, I remember walking into a room at a charity called Body and Soul, or rather limping in because my peripheral neuropathy was awful, on a crutch, and seeing this room full of people who were all about to eat a meal, and they were happy. And I remember looking at them, laughing and joking and thinking, why are they so happy? I am not happy, you know. And then I got to know them, and then I thought, yeah, okay, maybe you can be happy again too.
Fantastic. Wonderful. Thank you very much, Jo. And I've got a question from the audience. I'll pose this to Tristan, and then perhaps we could all have a bit more of a chat about this issue. Would injectable treatment be good for older people with HIV, especially if they find it hard to remember to take their tablets? Tristan, what do you think?
Thank you. Complicated question. So many people will be aware, but if you're not, there's been recent approval, certainly in the US and in Scotland, and now finally in England as well, for injectable treatments for HIV. These are 2 injections, one called cabotegravir and one called rilpivirine. And the initial license in the UK is for these to be given 8 weeks apart. Now, we don't yet have them in clinics in England. Some people are using them in Scotland, and there will be clear guidance. There's already guidance actually for clinics on the British HIV Association website, which is very helpful. I think the guidance initially will be very cautious because in the trials for these agents, they do work very well, but there are a small number of failures for those on treatment and a small number of people who develop resistance. Nonetheless, they may be very convenient for some people. I think 8 weekly injections means that people will have to come to clinic every 8 weeks, so 6 times a year, which will be more appointments than people are commonly used to. So although it sounds like they'll be more convenient, you have to think about whether you do want to go to clinic 6 times a year instead of twice or less. And people probably will need initially to have a viral load every one of those visits. So the answer to the question, would they be good for older people, is that they may be, provided people will be able to attend a clinic every 8 weeks, are happy to have 8 blood tests a year, have not had a side effect to the components before, have not failed treatment before. And so I think the honest answer is that for some individual people, they may be useful. For other people, it may not be so appropriate. And we just will have to identify people initially very carefully whilst we build confidence with these regimens. But they certainly do offer people a choice for a different way of receiving their antiretroviral therapy.
Wonderful, thank you. And how do people feel about injectable treatment? Is that something that's of appeal to you?
I have to take a lot of pills anyway. So I'm closer to getting blister packs than I am injections.
Okay. Well, that's interesting to know. And Rebecca, I'll ask you. I know that it's an issue that sometimes comes up in the sessions that we do, that sometimes people feel a bit overwhelmed by the number of tablets that they're taking. Is that something that you've been hearing?
For some, I guess there's a term for it. It's and please correct me, someone, if I'm wrong. It's about fatigue, tablet fatigue. And people do get tired, you know, especially if they've got lots of other things to take for other conditions. So, and some of them might be in the morning, some at lunch, some without without food, and some with food, and it makes it terribly complicated, and people do get a little tired. But I guess it's referring to what Tristan said. It depends on your lifestyle. It depends on what you can cope. I'm sitting here and thinking, it'll be much more of a challenge for me to remember which appointments, you know, 8 times a year to go to, than remember to take my tablet every day, because I've gotten into such a routine. It almost feels like, oh, I've forgotten something. Oh, yes, I need to take my tablet. For me personally, that's far easier than having to then develop a new regime and, you know, that kind of thing. But yeah, you do get people that feel, oh, this is too much and I'm tired of taking the tablets and all sorts of things. But I think it's a phase that we all go through. At some point you think, oh, do I really need to take these? But once that's passed, and again, peer support helps you manage how, you know, it comes up with tips on how you can manage these things. So yeah.
Yeah, absolutely. And I would certainly emphasize that if anyone feels that way, it's incredibly important that you speak to your doctor about it.
Yeah.
Don't suffer in silence.
Definitely.
Joe, how do you feel in relation to potential side effects from taking treatment and solutions to that?
Now you've got me started. As far as injectables are concerned, what worries me about injectables and or the other things that may come up, like implants, is the tail. In other words, how long the drug will stay in your system, because research does suggest that it lingers longer in women than it does in men. That may simply be a factor of a small body mass. It may be because women process medication in a different way. This is a subject where the research at the moment does not have, or very frequently does not have, any or many women actually involved in it, which is of concern. And the side effects that are there now with treatment are so much less than they were with, obviously, the original medications. And different people react in different ways. And if anybody who is watching this does have side effects, then they should talk them over with their clinician and see if there is an alternative medication that they can take. Richard was mentioning earlier, which Tristan, of course, spelt out for us, one of the more unpleasant side effects that can happen with treatment for a lot of people, which is an extremely active digestive system, if I can put it delicately, necessitating a certain amount of discipline before leaving the house in the morning, if I may put it delicately in that way. But not quite as sensitive, but lack of sleep or vivid dreams, disturbed sleep. That really is something which affects so very, very many people. And I don't know if there is a medication where that doesn't happen to a greater or lesser extent.
Wonderful. Thank you.
I would just say as well, in addition to that, we know that people who are let's say, slightly happier to voice their concerns are the ones who have their medication switched. And so I would strongly encourage, as you suggested earlier, Joe, that if you're having side effects, you're getting them in between appointments, write them down. And I think, Rebecca, you said it as well, like, you know, think about what you need to discuss when you come to your appointment. Write these things down, because if you get a bit shy when you come in, or you're not a forceful person, or you think it's something you don't want to bother the doctor or the nurse with, at least if you've got a list, you can say, would you just mind if we work through my list? And they'll see what you've experienced in the last few months, because it is the people who tend to say, I've got this is unbearable. You know, they'll be the people who get switched. And actually, if you're just a little gentler with the way you want to converse, then just get it written down and you can go through it like a list, and people will switch you then to something more appropriate if these side effects are really standing out.
Absolutely, that's really good advice. And Rebecca, I wanted to raise with you one thing that I'm hearing a lot, particularly women of colour, is people just not being believed when they go and they speak to their doctor about side effects. What advice would you give?
Oh, I'm going to say that also is a really tough one. I think it depends on who you're sitting in front of. If it is your HIV consultant, I think they're far more likely to listen. And that's not to say GPs or primary care doesn't listen, but I think our HIV clinicians have learned over the years that actually, I don't even know if the word is learned, but they're slightly more alert to anything that we do bring up. So, you know, I think it depends on, the best way I would answer that is it depends on who you're sitting in front of when you're having that conversation. Because, yeah, if I went to my GP, this is where the ping-ponging comes in again. He will say, oh, well, that sounds like an HIV matter. Can you go back to your HIV consultant? And then you just sort of find yourself, and this is where you learn to be slightly more assertive. I just wanted to quickly add on to what Tristan was saying in terms of having these conversations. I think sometimes even something as simple as, because my lifestyle doesn't allow it, and I don't mean that I'm partying all night and therefore I can't take my tablets. When I say lifestyle, I'll give my example. When I started my treatment, I had to take my tablets twice a day, 8 o'clock in the morning and at night. And I found that taking it in the morning was really, really difficult because I had 2 young children that I needed to get ready for school. And so I found myself taking it at 8 o'clock or maybe midday after I'd gotten to work. And as soon as you get into work, you just get going. So I was missing a lot of my morning doses. And when I explained that to my consultant, he said, okay, we'll try and find something that you can take once a day that works at night. And I've been adherent much, much better because I've had that conversation with my consultant. So, you know, don't be shy. And as Tristan says, write it down if you need to, just so that you can have a conversation with your consultant so that they can give you the best option. It's for you at the end of the day. So that's really, really important.
Yeah, brilliant. Very good advice indeed. And Joe, patient-reported outcome measures. How important is that?
Well, it's how useful is that actually, and very timely, because the press release about patient-reported outcome measures, or PROMs, went out today. It was a 3-year project altogether with input from people from the community very much at the beginning. I was actually involved in it then, from Mbewe as well. And it's on Twitter now. If you look at KCL, King's College London's Twitter, you'll see it. Mbewe's also tweeting it. Patient-reported outcome measures is what it says on the tin. It's like a list, a checklist of things that are important to people living with HIV. The idea being that if that's used by a clinician, it will, in a very quick way, see if there's been a change. This time you're seeing the clinician from last time you were seeing the clinician. Sleep, for example, could be one of the things that's in that. And it can be done before the clinician appointment. So it's rather like the lists that Rebecca was just talking about, or Tristan was talking about, but it's a formulaic way of doing it, which hopefully will be very useful in terms of time saving and communication.
Wonderful, thank you. And Richard, I want to ask you about the impact of COVID on healthcare. For many of us, we're now having telephone appointments rather than seeing our doctors face to face. What advice would you give to someone who may be struggling with this issue?
The list thing keeps coming up, but it's not so much a list of things, but a list of ideas that you need to talk about with your doctor. It's not a specific symptom, because the symptoms we've run over so many times. But it's the idea that how you're going to can you cope until you next speak to your doctor. And 6 monthly phone calls is what I currently have. And I always think of something just as I put the phone down. Consequently, I have done the list thing despite having had the same doctor for a very long time and having a good relationship. I have to remember what needs to be said and realise that there is a very tight limit on her time. So it's as much as you can be prepared, but as well as all the business about what symptoms you're managing at the moment, I do think it is still relevant to talk about the other stuff, about how you're feeling, and the interaction between how we cope psychologically and how we cope physically. It is so intertwined.
Yeah.
And I think it's perfectly reasonable to talk about how we're coping with the world in general with your clinician for those 10 minutes on the telephone or whatever we've got.
Yeah, absolutely. Very important indeed. And a question that someone's raised with me is, how do you feel about being cured of HIV? Because that's something that comes up as a conversation quite a lot. Is that something that you're hopeful for?
Exactly. You just
the last few minutes.
This is language, isn't it? Because to some extent, we have with completely suppressed virus a functional cure. We're not, because we've still got the virus, but it's not affecting us in anything like the same way. If we're talking about viral eradication, then that's a completely different thing. But it's always 10 years off. It's always 10 years time. Hopefully in 10 years it will be here, and as I will then be approaching 70, it will obviously see me through to becoming 100.
Yeah, absolutely. And what would you say about, very briefly, Tristan, about cure studies?
I agree with Richard, and I think one of the other things we're not sure about is we don't know if some of I talked about inflammation a bit. We don't know how much of that is triggered at the beginning of your infection, and so whether taking the virus away even more than being undetectable will give you any more benefit in terms of life expectancy, I don't think is very clear. So you'd have to weigh up very carefully whether the cure itself was going to give you more toxicity and more harm than just living with an undetectable virus.
Wonderful, thank you. Yes, go
Sorry,
ahead.
I was just very quickly going to say, I think there are psychological things that you need to think about. That's a completely different lifestyle. I've been taking treatment for 18, 20 years, and then suddenly be told, well, we've got one thing that cures it all. It's a really different mind shift as well, I think, and we've got to take that into account.
Okay, fantastic. Thank
I'd
you.
love to be cured of herpes. That'd be a lot more useful. Anyone who gets recurrent cold sores will know that.
No, we were going to get tonight.
Wonderful, thank you. I've got one final quick fire question for all of you, because we are running out of time. One piece of advice to someone getting older with HIV, and we'll go with you first, Jo, and work our way around.
Do things you enjoy, eat healthily, have fun, and have at least one small adventure every week, and be grateful for it.
Wonderful. Tristan?
stay active, keep your muscles moving, keep your joints moving, and stay active. It's really good, not only for, as Richard mentioned earlier, not only for physical well-being, but for mental well-being also.
Wonderful. Rebecca?
All of what they said, but also I think it's really important to keep your mind healthy, because as Richard says, your healthy mind is a healthy body. So yeah, keep your mind healthy, keep your mental state in as good nick as you can.
Wonderful, thank you. And finally, Richard.
All of the above, but also my late partner's instructions: keep on having fun.
Yeah.
You know, it's a very brief way of putting it, but you know, there isn't a choice. You can still have fun. Do it.
And
Wonderful.
don't neglect sex.
I was about
Indeed.
to say that, Tristan. I was going
Counts
to
as
say,
fun.
where does sex come into it? Definitely.
Absolutely. Very good advice indeed. Well, we have run out of time. This has gone so quickly, but I would like to thank you all so much for giving up your time and sharing your very important insights for this broadcast today. I'd like to thank Disruptive Live for doing their absolute wonderful wizardry, and I would also like to thank Matthew Hodson, who has been behind the scenes, and I would like to finally thank the James Tudor Foundation for supporting this event. And thank you all for joining us today. This has been wonderful, and we will see you soon with another episode of aidsmapLIVE, and I will be joined by Matthew Hodson very soon for a new series of aidsmap chat. So thanks very much, and see you all soon. Bye.